Good morning, friends. I'm Dr. Anupam Agarwal from dockieslive.com, an educational initiative by GP Clinics. Friends, today is the last episode of our monthly webinar series. This is the 24th webinar being run for last 2 years every month. We thank you all for your overwhelming response to this educational initiative. Friends, you must have noticed that we could make this 2-year long series possible even without any support from farmers. Friends, it is your love, affection, and overwhelming response that we are happy to announce to continue this series with Dr. Y.K. Amdekar in the new year also, but in a new format. This new series will be named as 9-Minute Craft, in which a 9-minute video by Dr. Y.K. Amdekar will be uploaded once a week on our YouTube channel, dockieslive.com. It will start from the month of February in 2025 and will continue for the entire year. So friends, in total, there will be 52 episodes throughout the year. We hope you will like this new initiative, new video series. And for further details, you may refer to GP Clinics print edition. The content of each video will be unique and will provide tips which will be useful in your daily practice. And as usual, the transcript of each video will be published in GP Clinics print edition every month. Friends, all previous videos and this new series will be archived on our YouTube channel dockieslive.com so that you can watch them at your convenient time. With this brief information and background, friends, let's come back to today's topic, which is approach to hypertension. Dr. Y.K. Amdekar, as you all know, needs no introduction and is the speaker for today's session as usual. So over to you, Dr. Amdekar, sir.
Thank you very much, Dr. Anupam, and good morning, friends. I think today is the last of the series, and as Dr. Anupam said, we are going to launch another new format, but continue it throughout the year. And I hope you all join us every week. But this is going to be archived as well, and you can see it at your own convenience. And Dr. Anupam will keep you informed about the timings, etc. So I think let's get to today's topic, and that is a clinical approach to hypertension. Can I have the first slide, please? I think this is an important part of our clinical practice, uh, maybe far more important in adults, but also equally important in children. And as usual, I'll give you some basics of what blood pressure is, and that will help us to kind of understand the sequence of our discussion in a much better way. Now, blood pressure is the force that the flowing blood achieves against the arterial wall, and that is what is called as the blood pressure. But systolic blood pressure really occurs, pressure occurs when the heart is contracting. And I think therefore it's a measure of how good is the contractility of the heart. Make a note of this. This is very, very important for us to understand what does that blood pressure tell us. So the systolic blood pressure denotes the heart contractility, whereas the diastolic pressure is the pressure exerted during resting phase, that is diastole, and it represents the vascular resistance. So by systolic and diastolic pressure, you get an idea about the ability of the ventricles to contract, and also how good or bad is the vascular resistance is known by the diastolic pressure. So the pulse pressure is the difference between the systolic and diastolic pressure, and it represents the stroke volume of the heart, which means that how much is the volume of blood ejected. You know that in echocardiogram you get an ejection fraction, which is a measure, but a stroke volume is represented by the pulse pressure, the difference between systolic and diastolic, and mean arterial pressure, which can be calculated from systolic and diastolic pressure by the formula systolic blood pressure reading plus twice the diastolic blood pressure reading divided by 3 is a mean arterial pressure, and it suggests how well the organs are perfused. Can you imagine what that echocardiogram tells us about the contractility of the heart and ejection fraction? The blood pressure, systolic, diastolic, and pulse pressure, along with mean arterial pressure, also gives you an idea not about the contractility of the heart, but also about the peripheral vascular resistance, not only about the stroke volume, but also the measurement of organ perfusion. Friends, and how important is the understanding of blood pressure? And today we will discuss a problem of hypertension, but I thought this basic will be very important for all us to learn. And you can imagine how blood pressure changes can almost tell you how good is the heart function and what is the vascular peripheral resistance is like. In other words, it's a good measure of a cardiovascular system function. Well, we all know that normal blood pressure of an adult is 120 by 80, but in children, roughly, it's a rough measure that age in years uh, plus 90 is the systolic pressure, and age in years plus 55 is an average diastolic pressure at that particular age. And I think this is a simple formula to know whether you are dealing with hypertension. But finally, the hypertension is considered only when the blood pressure has gone beyond 95th centile for the age, sex, and height of the patient. And I think this is important. It could be a high systolic as well as a high diastolic, but we must go by the maximum allowable normal limits of blood pressure, and that is the 95th centile. Can I have the next slide, please? After knowing the basics, we, of course, all of us know, but just to revise, that sphygmomanometer is the best method, routine practice that we use of. And it's important to be sure that you also palpate the pulse before you get on to auscultating the pulse. And this is because there is often an auscultatory gap when you release the pressure over the sphygmomanometer, and there would be a beginning of the auscultatory sound, but the sound may disappear in between and again reappear. This auscultatory gap depends on largely how are the blood vessels in terms of stiffening. And as your age advances and atherosclerotic changes occur in the blood vessels, this gap increases, and the gap is normally about 10 millimeters of a mercury as you go down the mercury column. But in atherosclerotic senior citizens, this auscultatory gap could be even 20 or 30 millimeters of mercury. Therefore, make a habit of palpate the pulse first while you release the pressure on the sphygmomanometer, and then you get a maximum reading. Then you start auscultating so that you will not miss the right kind of systolic blood pressure. I think this is important, and I'm sure all of us know it, but some of you might go straight to auscultation, and therefore I thought this is important to go by that. I think there are other methods like the electronic digital meters, which are not very accurate, and especially in senior citizens with atherosclerosis, these may give an erroneous result. And therefore, ideally, the sphygmomanometer, of course, in ICU, you can have even an intravenous or intra-arterial monitoring, but that is not our game. And finally, therefore, we must know one thing which is very important to my mind, that ideally every one of us must have a blood pressure recording once a year. Well, friends, then as uh, family practitioners, you might have a routine checkup yearly of every patient under your care, because an essential blood pressure hypertension, or what is known as a primary hypertension, starts very early, sometimes even in childhood. And if you pick up that trend that he is going to develop a primary hypertension by the age of 30, 40, or 50, whatever, you might diagnose the earliest stage of a developing hypertension much before actually hypertension develops. And that's why it's not a bad idea to infuse in the minds of your regular patient that they must come for a yearly follow-up, which of course will include many other things, but most important is the blood pressure. And I think having said all this, let's get to the next slide, please. And that talks about the causes of hypertension. Well, I won't dwell much time on this simply because you know that hypertension is primary, which means there is no obvious systemic cause, and this is largely seen in overweight or obese individuals. And of course, it's also seen as the age advances and the vascular compartment, the blood vessels start getting little stiff and rigid, and the blood pressure proportionately starts increasing. Well, therefore, as the age advances, a primary hypertension is often presenting to you as a disturbance or a defect. But I've already made a mention that this kind of a developing primary hypertension early in middle age is not uncommon today. I'm sure you know more than me on this, but I want to emphasize that it could be diagnosed in a pre-hypertensive stage. And it is that stage where you can interfere with the patient not by a pharmacotherapeutic agent, but by change in lifestyle. And this is a very, very important. Primary hypertension is to an extent preventable hypertension. When it comes to secondary hypertension, it's usually due to renal disorders, commonly renal glomerular or renal parenchymal disorders, or also renovascular disorders like the renal artery involvement. Of course, it could be due to uh, any other cardiovascular disorders like coarctation of aorta or any Takayasu's disease, where there is an obstruction to the aortic or a large blood vessel flow, and it could be due to endocrinal disorders like hyperthyroidism and typically an adrenal hyperplasia or an adrenal tumor. And occasionally it could be due to a drug induced as well. Having given this idea about the basics, let's get on to case discussion as usual. And I will present you 8 different cases of hypertension, and you will pick them up by a good history and clinical examination. Can I have the next slide, please? Now, before that, just a simple clinical approach. I'm sure everybody knows it well, that hypertension is often asymptomatic. But when symptoms develop, you have already missed the pre-hypertensive stage, and the symptoms could be very vague, like blurring of vision, maybe nosebleeds, maybe headache, and that could be also including chest pain, breathlessness on exertion, and anxiety, etc. Well, we must confirm the hypertension when it has gone past 95th centile, and physical examination, of course, rules out any renal endocrinal disorders as well as the peripheral vascular disorders, drug injection, etc. Let's have the next slide, please, and let's start discussing the case. Now, this was a young adult who presented with periorbital mild puffiness and oliguria for the last 2 days. He's a healthy person and started all of a sudden. The examination shows a healthy adult with mild edema and the blood pressure is certainly high. Now, what's your probable diagnosis only on this? Could it be acute glomerulonephritis? Could it be nephrotic syndrome? Could it be acute pyelonephritis? Or it could be none of the above. Your time starts now. Excellent. Uh, I'm sure that this is a pretty common disorder. Can I have the slide back? It is a common disorder, acute onset, acute glomerulonephritis. I think the point to remember here is that anybody who suddenly starts presenting an acute periorbital puffiness is likely to be an acute renal disorder, or rarely it could be an acute angioneurotic edema as a result of some allergy. But rest all conditions which present with edema or puffiness of face or eyelids are never acute. They may be acute on chronic, like a chronic liver disease presenting acutely with puffiness of face, or an edema feet in a cardiac disease presenting as an acute manifestation of edema, but in a chronic person, chronic unhealthy individual. Whereas this typical acute glomerulonephritis is a very healthy person who develops often 2 or 3 weeks after a common throat streptococcal infection or a skin infection and develops this typical acute glomerulonephritis. Well, point to remember is that this is often associated with hematuria, but the hematuria may not be visible by eye, but there are microscopic red blood cells in the routine urine examination. Therefore, this was a typical acute glomerulonephritis. And another point to remember is that if it occurs after typical streptococcal upper respiratory or skin infection, the prognosis is excellent, and most of them, 99% of them, recover without much specific treatment, except occasional patient need antihypertensive drugs. But the prognosis is very good. But any other infection also may lead to acute glomerulonephritis, like viruses or many other bacteria, and the prognosis may not be equally good. Let's have the next case, please. The next case is a young 2-year-old boy who presented with generalized edema. By generalized edema, I mean more than one part of the body showing edema, often face and periorbital region, and also in the legs, but it could be in the arms, it could be also in the abdomen, and so on and so forth. So this 2-year-old presented with acute onset of generalized edema, and the physical examination showed a healthy child, but with generalized edema, and the blood pressure was also raised 140 by 95 in this child. Now, what is your probable diagnosis? Again, is it an acute glomerulonephritis? Is it a nephrotic syndrome? Is it hypothyroidism? Or is it a chronic renal disease? Your time starts now. Excellent. I almost was sure that you will all just get it. Um, let's have a slide back, please. This is the classical nephrotic syndrome. Okay. Now, the point to remember on this slide is that nephrotic syndrome often presents without hypertension. But this child is presented with hypertension in a nephrotic syndrome. The previous slide had hypertension with mild edema. This child has hypertension with massive edema. That's why we call it nephrotic syndrome. But this means that this patient has a complicated nephrotic syndrome. It means it is not likely to go about with good prognosis. It may be steroid resistant nephrotic syndrome. And I think hypertension in a nephrotic syndrome is a kind of a warning to you that this may be as if a combination of nephritis and nephrotic syndrome. That's not the right word, friends, because nephrotic syndrome is also nephritis, but it is affecting the epithelium of the glomerulus much more than endothelium. And when endothelium is isolatedly affected, we call it an acute glomerulonephritis. When epithelium is in isolation affected, we call it a nephrotic syndrome, which has massive edema but without hypertension. And this child has a nephrotic syndrome, yes, but possibly an extended nephrotic syndrome or a complicated nephrotic syndrome. Such a patient is ideally referred to a nephrologist because you expect some trouble on progression. Can I have the next slide, please? The next slide, please. Now, the next is a young female adult who presented with high fever for 4 days, followed by skin rash over the face. There is no edema in this patient, but a high fever and a skin rash. Just because of this history, one would start thinking whether it's some common viral infection, etc. But common viral infections do not have fever high for 4 days. They may not have skin rash only on the face. It's often over the limbs or all over the body. And there is often cold and cough accompanied with viral infection. Therefore, you have enough reasons to anticipate it not to be a simple viral infection. And with that background in mind, with a good analysis of the history, you examine this patient and he was a healthy but a febrile patient and the BP was higher, 160 by 100. Take a note of this acute onset healthy adult female with skin rash and a high blood pressure in a highly febrile situation. What's your take on this? Can it be an acute glomerulonephritis? Could it be acute pyelonephritis? That's a urinary tract infection. Could it be a nephrotic syndrome? Or could it be none of the above? Your time starts now. Can we get back to the slide, please? Well, acute pyelonephritis is an acute urinary tract infection with high fever, but never presents with any skin rash. Therefore, this cannot be an acute pyelonephritis. It is not acute glomerulonephritis because there is no periorbital edema. It is not nephrotic syndrome because there is no generalized edema. And therefore, it's something different. Well, it is therefore none of the above. And what is this? This is typically a nephritis caused by SLE in a female individual, adult female individual. Friends, we also do see, especially in older children, but surely it's more common in females, more common in adults, and it causes nephritis, not a typical post-streptococcal glomerulonephritis, which comes with acute onset of periorbital puffiness and hypertension, but it is the nephritis, all right. It is the nephritis that can linger on for a long time. It is something that immediately needs a referral to ideally a rheumatologist and or nephrologist. But a rheumatologist would be ideal because this is an autoimmune rheumatological disorder. The point to understand is you may have a hypertension due to nephritis, but it may not be a simple glomerulonephritis. What was that glomerulonephritis was like? Not a high persistent fever. That's very, very important. And that was without skin rash, but with periorbital edema. This is with high fever and a facial skin rash. This is typically a butterfly rash that is described in SLE, and SLE can present with complications straight off because SLE is a vasculitis. And when renal glomerular vasculitis occurs, renal glomerular capillaries are affected, then you get nephritis. But it's not a simple acute glomerulonephritis. And this is something that is extremely important for a rheumatologist to manage well. It's not a cup of tea for you and me. As a generalist, and this is because SLE with a renal complication is a very serious disease and needs a prolonged immunosuppressive treatment. But friends, you and me as a generalist can pick this up as early as 4 days. What a beauty of medicine that you can pick up what a rheumatologist will pick up later in the course and will ask us, why did we not refer early? This is how we need to learn where we need an early reference. We need an early reference in nephrotic syndrome with hypertension because it's a complicated nephrotic syndrome. And we need to also refer this to a rheumatologist, not to a nephrologist primarily. And this is another area where I want a good generalist family physician to pick up as early as possible such disorders that possibly even a super specialist may not pick up so early. Can I have the next slide, please? The next slide is an older child, almost a young adult, 16-year-old, who presented with generalized weakness over the last 1 year. Take a note. He has got some chronic disease, but his only symptom is general weakness, which means that a system which is involved in this patient for a year, a long time, has no obvious manifestation, but there must be a hidden manifestation. And I think take a note of this. Physical examination showed a very short individual. His height is affected. He has got a moderate pallor and his blood pressure is high. And he has also a cardiomegaly. Take a note of all these combinations. A significant anemia, a significant short height. That means he has not grown well in terms of height. He has a hypertension and he has got heart enlarged. What is your probable diagnosis? Can it be aortic stenosis? Can it be primary hypertension? Can it be adrenal hyperplasia? Or could it be none of the above? Your time starts now. Can we have the slide back? I am amazed to see that every time, even in difficult cases, good 50% of you have known that the first three probabilities put on this slide are not the ones. And there is something else. Not a bad idea, not a bad clinical acumen. Okay, you may not know what is this none of the above. Okay, that's fine. The last slide, none of the above had an SLE nephritis. Well, that may not be necessary our way of diagnosing such a condition. Of course, you can be one up over the others, but it is a good idea at least to know that this is something sinister, this is something unusual, this is something atypical, and you need a cautious approach or even a reference early. Now, this is a chronic process. Anybody who has got a generalized weakness for a long time but without any apparent system manifestation. Had it been cardiac, he would have been having palpitation and breathlessness. Had it been respiratory, he would have been coughing and becoming breathless. Had it been a liver disease, he would have had abdominal distension and jaundice maybe. So many organs affection for a long time are not hidden, but two organs in the body which are often hidden in terms of manifestation which point out to those organs. One is the kidney and another is an adrenal. Friends, this is going on for a long time. He has suffered in terms of his growth. He is moderately pale, so he has a multi-system affection of his chronic disease. And finally, he comes out with a hypertension, and a cardiomegaly is secondary to hypertension. It's not a primary heart disease. And this is the typical story of a chronic nephritis, where edema or puffiness may not be even visible, but the chronicity should make you even examine further, investigate further for a chronic renal disease, and you are sure his routine urinalysis may show a lot of abnormalities, but his serum creatinine has probably already gone up high. This is typically a chronic nephritis. Chronic nephritis could occur out of multiple diseases, and this is again an individual who needs an early referral. Point is, how early could you have picked him up? You could have picked him up as early as 2 weeks of general weakness when you could not find any cause, but he's certainly feeling weak, he's not eating well, and I think a very close, detailed examination might pick up a mild edema over the feet, or you might pick up an early hypertension. This hypertension has gone on for a long time to cause a cardiomegaly, and you can imagine at 2 weeks of this child's illness, he could have been picked up as an early hypertension in a child who presents only with weakness. Look at the fun of how we could analyze many vague symptoms and not miss important things. Can I have the next slide, please? The next is again a young child, a 2 year old, who presents with breathlessness and only for last 2 weeks. Imagine the first individual presented only with general weakness, and you picked up a renal disorder with hypertension. Okay, no symptoms of renal disorder whatever. Now, this young child presents with breathlessness. You don't know whether it's a cardiac, respiratory, or severe anemia or whatever. You have no idea. But it's an acute onset. Okay. And he has no cough, so it's unlikely respiratory. So it must be a cardiac breathlessness. But cardiac breathlessness in a healthy, normal person just 2 weeks ago. So this is an acquired heart disease. Our examination surely shows a healthy child with cardiomegaly and a 120 by 95 is a hypertension at 2 years of age. We said 90 plus age in years and 55 plus age in years, systolic and diastolic. This is a hypertension. And what is your probable diagnosis? Acute myocarditis, aortic stenosis, vasculitis, or coarctation of aorta. Your time starts now. Can I have the slide back? Acute myocarditis is acute cardiac failure, but hypotension. Because the myocardium is not working well, so contractility is lost, so systolic pressure is down and not high. So it is not acute myocarditis. Aortic stenosis presents with shock, but may present with also hypertension and a cardiac failure, but it will be not in a healthy person of 2 weeks. It would have come up much earlier because it is a disease which is severe enough, it should present early, and that would be even in the first week or first few months. If it is not severe, it may not present even in older child or a young adult. So it's not aortic stenosis. It's not vasculitis because vasculitis is generally with fever. Like you have an ACLE with vasculitis, renal vasculitis. So this is quite different, and this is typically a coarctation of aorta. It's a vascular obstruction. You're right. Vasculitis is also vascular obstruction, but that is with fever and a sick person, whereas this is a healthy child, and this is typically coarctation. What what does this patient tell us? Every time you see any patient, especially for the first time in life, you palpate his posterior tibial pulse or a femoral pulse. It's the only way a good general physician can pick up an aortic obstruction and the common cause being a coarctation of aorta. Make a habit of putting your finger on a radial pulse and immediately on a posterior tibial pulse. It's a habit. You may pick it up maybe once in 5 years, but you would score over many others and you would be happy and thrilled that you picked up a coarctation of aorta, which is often asymptomatic. This is an important of a thorough physical examination. And let's make a habit of some of these points that I am raising on this discussion, that I always palpate a radial and put my hand on the posterior tibial just to be sure that the blood supply to all the blood vessels is normal. Can I have the next slide, please? Now, the next is a young adult again with an suddenly increased 6 kilograms of weight in the last few months. So he is becoming overweight all of a sudden, a reasonably acute onset of gaining weight. So it's certainly not a usual obesity or an overweight person. And when you examine this person, a young adult, 72 kilos, initially was only 66, he has gained 6 kilos. He's mildly breathless. His blood pressure is high and he has got a mild cardiomegaly. What's your probable diagnosis? Is he hypothyroid? Is he having a primary hypertension due to obesity? Is he having a cardiac failure? Put up your probability and see what you are looking at. It could be an adrenal hyperplasia. Your time starts now. Can I have the slide back? We are all equally confused, yes. But take a note. This is an acute onset high overweight. Acute onset overweight and hypertension is a classical story of an adrenal tumor or an adrenal hyperplasia. Rest all disorders have either no weight gain or a mild weight gain due to edema, or not sick, healthy, sick or SLE, sick or nephrotic with complication, healthy or nephritis, or a plain simple nephrotic syndrome. But this child is healthy looking, but mild breathlessness, hypertension, and most important is a sudden increase in weight. Friends, anybody who suddenly increases in weight is not to be ignored at all. The diagnosis is only between a massive edema, which is hidden, like a massive ascites, which is otherwise asymptomatic, but you have a story of an abdominal distension, or a typical adrenal hyperplasia where you get a sudden increase in weight. This is an adrenal disorder. It could be adrenal tumor. It could be a benign adrenal hyperplasia. Again, a need to refer to an endocrinologist. Can we imagine? We once referred to nephrologist, another to rheumatologist, a third to an endocrinologist. That's the beauty of a general physician, that he knows where to refer and he knows how early to refer. Can I have the next slide, please? Now, the next is a middle aged, healthy adult who was noticed to have blood pressure moderately raised during a normal check. Okay, physical examination shows that his weight is certainly heavy. What's your probable diagnosis? And what would you do? I don't want your diagnosis. Okay, diagnosis is simple. But I want you to vote for, would you repeat blood pressure record the next day, even at including one at home if possible? Would you do urinalysis and renal function test? Would you follow up without intervention? Or we will give you a small dose of the amlodipine. Your time starts now. Then I have the slide back. Very good. Almost all of you are back there, but I want to discuss between four, which is the ideal thing. The first is confirm hypertension. I told you in the basics approach, confirm hypertension, especially when it is mild. 140 is just a borderline hypertension. 95 is certainly worrying you. Now, there is something like a white coat hypertension. And what is white coat hypertension? When a patient is in front of a physician who wears the white coat, now the patient is a little anxious, worried when he is told he has got a hypertension. It could be totally because of his anxiety. But when you do it again at some other day, or he does it at home by the digital reading, he might be 120 by 80. So, white coat hypertension is a mild hypertension, and it could be something that you confirm before you rush into a management. This cell certainly doesn't need to rule out secondary hypertension, largely because he has no other issues. He has come for a routine check, and majority of secondary hypertension are significantly high blood pressure, not a borderline hypertension. So there is no need to further investigate him. Would you just leave him for a follow-up? Maybe accepted, but we need to be cautious about it. he might start going even further high, and therefore he needs to be checked every few days, maybe twice a week. And what about small dose of amlodipine? Not necessary because it's not bothering him at all at this phase of time. But what is more important is if his weight is little more than expected, he's an overweight or an obese, then this is the time to intervene and give him the advice of how he should change his lifestyle, which means he should be more physically active, he should be careful in what he's eating, he should aim at reducing his weight, and he should keep his mind cool, not stressed, not easy to advise, but give him some piece of advice how a mere change in lifestyle can allow him to go further in the few years to come before really a real hypertension catches up with him. So you can delay the progress of hypertension by picking up such a person. And I already said it's a good idea if you promote in your regular patient clientele that adults must come once a year to you for a routine check. That routine check may also include a good physical examination. See that there is nothing that you can pick up early, and blood pressure is one of them. All right? Good. Let's have the last case. Next case, please. This is another healthy 10-year-old who present with breathlessness over the last few days. He shows a heart rate of 120, a respiratory rate of 30, and he has got a hypertension. He has got a cardiomegaly, and his urinalysis as well as renal function test are all normal. Okay. Now, your probabilities are acute glomerulonephritis, adrenal hyperplasia, hyperthyroidism, or none of the above. Your time starts now. Excellent. Can I have the slide back? I already told you that two organs, adrenal and renal, do not present with any obvious symptoms sometimes, but awake symptoms like adrenal with excess of weight gain and hypertension, and the renal maybe only with hypertension, chronic or a very minimal edema, and so on and so forth. Another endocrine, which is not often with isolated problem like this, but could occur because you have not tested a mild tremors. Okay. Now, mild tremors are not even often reported by the patient, but when you ask him to outstretch his hand, you might see a mild tremor. And the point I want to make is that one cause of a tachycardia of unknown origin is a hyperthyroidism. Okay. And that could be an early sign of increased metabolic rate, which is what hyperthyroidism is. And then you check the blood pressure. The blood pressure is also high. Two put together called hyperthyroidism. Not common in children, but surely not uncommon in adults. And we knew them as Graves' disease with exophthalmos, tremors, but all that will come over time. But the early symptom could be simply just a tachycardia and a mild hypertension to begin with. Can I have the next slide, please? After discussion of several types of hypertension, which I showed you how they could have vague symptomatology, we will not spend much time on investigation. It is enough to say that primary hypertension does not need any further investigation, but we need to be very sure that chronic hypertension has not affected the eyes, not affected the heart, and that is important because hypertension can affect the eyes and the heart without your knowing or without the patient knowing and coming to you. Well, secondary hypertension is generally severe enough, and we have already discussed the renal, renoparenchymal, renovascular, peripheral vascular, endocrine, adrenal, hyperthyroidism, and whatnot. And according to suspicion, we will do all those kinds of investigation. Can I have the next slide, please? And the next slide, treatment. Again, I won't delve a great deal on that. Uh, Mostly, hypertension needs a chronic treatment. Secondary hypertension needs a referral, and a primary hypertension you can manage with a proper therapy. But if the blood pressure doesn't come down and you need a combination therapy, it's much better for a cardiologist to have a look because it's often a complicated issue. Having said this, can I go to the last take home message? The next slide, please. Well, nothing major, but we have learned today a lot. We have learned how to confirm hypertension, if it's borderline. Once you confirm whether it's primary or secondary, we need to track blood pressure reading for an essential hypertension to be picked up before really a hypertension it can be labeled. And I think that's the beauty of an early thing. Having said this, I will just make a small mention at the end of our 24 months of webinar series. I hope you have enjoyed every one of us. We have tried to give you the best possible way of an interactive lesson. And the next kind of presentation that Anupam has devised is really a 9-minute video. And you must be wondering, what am I going to tell you in a 1 9 or 10-minute video? I'm going to tell you the approach or the way to analyze more than tell you what the symptoms mean or a signs mean. And therefore, in the first part of the series for next 3 4 months, we will tell you how to approach and analyze the symptoms. And after that, I will tell you what do the each sign indicate to you. I will not tell you how to examine a patient. I will not tell you how to take the history, but I will give you something more in 9 10 minutes. And thereafter, I will not tell you what investigation to order. I will teach you how to interpret small little changes in the test results. And finally, then I would end up, as the time permits, over the end of the year with something more on non pharmacological management. I hope you join us on this. Dr. Anupam Agarwal, with his videos and GP clinics, is trying to teach every one of us and keeping us updated with the sole idea of disseminating knowledge, the knowledge that will be transmitted to use in our medical practice for the betterment of the community. Friends, let's join hands. And when Dr. Anupam requests me, he has many ideas how we could kind of make it very interesting to learn. And now he has devised a 9-minute videos. Please join him. He will tell you all the details before we get on to this project by early February. Thank you very much for being with me over the last 2 years and reading the summaries of all this in your GP clinics. I request many other family practitioners who are not yet the part of this whole story to join because this is a very, very good initiative that he has taken over the last several years and he is kind of extending it with different new ideas. These ideas will not be available in the textbook. These ideas will not come to you easily by attending a conference, but it will come to you at home by looking at your videos and joining on webinar. I hope you take the best advantage of it. Over to Anupam. Thank you very much for allowing me last 2 years on this project. I thank you with a grateful feeling that it gives me a great pleasure that I am likely to be happy doing it only because of people like you who make it possible for me. I would not have otherwise been able to do it. Thank you very much, Anupam, and thank you all our friends for participating in this. Back to Anupam.
Thank you, sir. Thank you very much for the kind words. And if time permits, should we take just one or two questions?
Yes, we can. We can.
Okay. So the first question is, how early in life hello,
Come back again.
how early in life does primary hypertension start?
Oh, that's a good question. Primary hypertension starts in childhood. Can you imagine that? Even pediatricians may have forgotten this. Therefore, in UK, every child at the school entry at 5 years and school exit at 14, 15 years must have a blood pressure record. Okay. But UK is more conservative like us. The US and European countries insist on yearly blood pressure record of every individual child or an adult. That's the only way to pick up primary hypertension. You don't call it hypertension, but you chart the blood pressure every year. And you see that the normal blood pressure at the lower end is now coming in the middle end and is reaching at the upper end. Before it reaches the 95th centile, it had started from 25th centile. You had 5 and 10 years in between to manage lifestyle. Once you see an obese person or an obese child, he's going to be obese forever. And the advice goes above his head and above his ears because he knows what advice doctors are going to give and he knows that's not acceptable to him. Friends, therefore, the right time to intervene in obesity, in weight reduction, and in hypertension is a yearly check. Promote this to your patient. Well, some of them will feel that you are just trying to get them more often to your clinic. Let them not come. They will realize when they come to you with a hypertension.
Next question is, how to suspect secondary hypertension?
Yes. I think a simple way is an acute onset hypertension, which is severe, is always secondary. And you palpate the peripheral pulses, you look at the renal disorder, you look at the adrenal and thyroid disorder, you just get a final diagnosis before even referring to a super specialist. And I think it will be a great honor for you to refer a patient to super specialist with a clinical made diagnosis. And he would wonder how good you are as a family physician that you are telling him, a rheumatologist, this is SLE. You are telling a nephrologist this is a complicated nephrotic syndrome. And you are telling an endocrinologist, look for adrenal or thyroid. It will give you a kick to do better. And I think learn to get the best out of it. It will make your practice happy and looking forward for learning more. I continued it at the age of 84. I have not learned enough. I want to learn more. And it's the fun.
So,
Thank you. I think, Anupam, we are running out of time, but as usual, you will send me all the questions and you will print it on your next GP clinic.
yes, sir. Thank you, sir, for this wonderful session. We hope this interactive session would have made learning interesting for attending doctors to help empower their practice. So, on behalf of doctorslife.com and GP Clinics, I thank all the doctors who have attended this session. So, friends, please note the date for our new series 9-Minute Craft starting next year. And the date of this weekly video will be released through our normal communication channels. So we plan to start this in February, probably 1st of February. And I would request all of you to please visit our doctorslive.com channel. All the videos, previous and the future ones, will be lying there for your viewing. And you can comment also over there, and you can subscribe to our channel. And a lot many other initiatives are also being planned. And I hope we'll be successful in our endeavor. Thank you very much. Once again, to all of you, good day.
Good day, all of you. Thank you.